Hello, everyone. We are going to start, but we are going to start with Dr. Dryden because she got a. I know. I'm sorry, Biba. She gets a flight, and we don't want her to lose her flight. So we are going to start with her. Let me say some words. You want to introduce yourself? Ladies and gentlemen, please applaud Dr. Dryden.
Yeah. Perfect, thank you. Good afternoon, everyone. I'm just setting my timer because I am a professor and you know that we like to go on and on and on. And I have a flight to catch, so I can't go on and on and on today. So let me just set my timer. I just want to take this moment to thank everyone involved with putting this together and all of the labor that went in and all of the volunteers and all of the ways that funds came together to fly us in, to have this food and to make sure that we could have this conversation in this way. For any of us who do this work, we know that this is a lot of labor. It could be frustrating. You're up late at night. You lack sleep. You're eating out of cellophane bags. So I just want to say thank you for doing that work. My name is Dr. Omi Sheree Dryden. I am the James R. Johnston Endowed Chair in Black Canadian Studies in the Faculty of Medicine at Dalhousie University. I'm also the interim director of the newly established Black Studies Research Institute that focuses on STEM, science, technology, engineering, mathematics, and medicine. And I am the co-lead of the Black Health Education Collaborative. But before all of that, I was a PhD student at the University of Toronto, OISE, and my research looked at blood donation. Most specifically, it looked at the kinds of stories, you can tell I'm a humanities professor, the information that we were being told through the donor questionnaire and how that information was deeply steeped in systemic anti-Black racism. I then went on to kind of map, not kind of, but to map systemic anti-Black racism in donor protocols from 1940 until about 2020. So what I'm going to speak about today really is the systemic anti-Black racism that frames how we understand science, how we understand safe blood, how we understand equity, how we understand justice, and how we understand inclusion. Because if we do not understand how systemic anti-Black racism functions, then we will be invited to these tables, but nothing substantive will change. Yeah? There will be a call to increase Black donors, but we will not be able to create generational Black donors because systemic anti-Black racism has A, not been addressed, B, not been accountable for, and C, not been taken seriously. So that's what I'm gonna map out today in 15 minutes or so. Oh, it worked. First, I wanna say just a quick land acknowledgement. I currently live in Halifax, Chibuktuk, the traditional unceded territory of the Maliseet, whose ancestors, along with the Mi'kmaq and Passamaquoddy nations, signed peace and friendship treaties with the British Crown in the 1700s. What we don't often talk about with treaties, though, is that some treaties were signed before the end of slavery in this country, which means that not everyone is a treaty person, right? Because if enslaved Black people were written into treaties, we were written in as goods to be traded, but not as distinct people and the collaborative work we do. So I name that. I also want to name the distinct societies of African Nova Scotian people and Black Scotian people in communities in which I live, and to acknowledge that Black and Indigenous people are working collaboratively in spite of anti-Black racism and anti-Indigenous racism and the ways that we move forward. If we understand colonialism, then we need to understand that slavery was part of that, and systemic anti-Black racism precedes this work that we do. As always, Black Lives Matter, Black queer and trans lives matter. We are in the International Decade for People of African Descent. it's important to make sure we specifically talk about Blackness and that it does not get encapsulated in people of color or BIPOC, but that we talk about Blackness and we talk specifically about anti-Black racism, and in my research, anti-Black homophobia and transphobia. I just wanted to give a shout out to Amber Hikes. I know there were rainbow flags are being flown all over at this time of the month. Happy Pride to everyone. But most specifically, I wanted to point to the Black and the brown stripe. So Amber Hikes, as you can see, is an American civil rights activist and community organizer who serves as the Deputy Executive Director of Strategy for the American Civil Liberties Union. Amber was the one that added the Black and brown stripes to the rainbow flag. And for doing that, she did it because she wanted to make sure it was more inclusive, that we were speaking about the anti-Black racism in queer and trans communities. But in doing that, she received death threats. And we don't necessarily think about how anti-Blackness works in queer communities. And so when we see this flag around, the question we need to ask is, great, we're celebrating Pride, but are they also talking about anti-Blackness? Because these stripes are about how anti-Blackness works in queer and trans communities. So are they being inclusive and talking about anti-Blackness, or are they just glossing over that? So if we want to create an anti-racist donor system, and I think this is what we want to create, at least it's what I want to create, I think others want to create this, we cannot get to anti-racism without reckoning with anti-Black racism. Even how we understand anti-racism today comes out of a history of Black scholars, Black activists, Black interventionists. And so if we want to get to anti-racism, it's important to reckon with anti-Black racism. My colleague, Dr. Ani Norm, and myself, we are the co-leads of the Black Health Education Collaborative, wrote this article that was published in January 2021, Time to Dismantle Systemic Anti-Black Racism in Medicine and in Healthcare. And I put it here because A, it was one of the first articles CMAJ ever published, but B, this conversation around addressing anti-Blackness in medicine and healthcare is one that's been happening for a while, but seemed to increase after the murder of Mr. George Floyd, and of course, what we were finding after COVID-19. So often people think of this image on your right, people think that this is what equity looks like, being objective and being colorblind. However, what you see in that image is if we're being colorblind, then we're actually not addressing the racism in the room. We are pretending that we're treating everybody equally, but we're not disrupting the racism in the room, which means, as we heard earlier, these social determinants of health of racism continue to exacerbate our poor health outcomes. And what usually happens in that moment is then they rely on a race biology model. Well, it can't be racism. It must be because you're Black, must be because of your race. What we argue, what I argue, and others is that we actually need to see race. We cannot be colorblind. We need to see racism. And that is not objective. Often when we talk about anti-Black racism, we're told we're not being objective, that we're being subjective. But in fact, if we're naming the elephant in the room, we've actually created conditions to make change, make substantive change, and hold appropriate people accountable. And if we're talking about anti-Black racism, we're also talking about structural white supremacy. And we have to name how that is present in blood donation, in healthcare, and how that negatively impacts our kin, our family, who rely on blood products as a medicine. So I don't have time to get into this slide, but what I wanted to talk about here is that scientific racism and race biology back in the day was just called science. But there's ways in which we see scientific racism and race biology manifesting through the donor protocols from 1942 today, but also through Canadian Blood Services and the donor questionnaire that has been put into place that likes to conflate, that has conflated geography with race. And also the refusal to acknowledge how geography's conflation with race has worked to disadvantage Black donors unnecessarily so. Just a quick tip, if anybody in the room uses the word Caucasian, you are using a word that was created through scientific racism. And as we say in our training with the MCC, the Medical Council of Canada, and the Royal College and others, what you really mean to say is white, because Caucasian really comes out of these schools of thought of monogeny and polygyny. Happy to talk about that in more detail at another time. What is anti-Black racism? We need to acknowledge the work of Dr. Akua Benjamin, who was at Ryerson, now called TMU, who coined the phrase anti-Black racism to describe policies and practices rooted in Canadian institutions such as healthcare, education, justice. Some folks from back in the day may recognize anti-Black racism as something that Stephen Lewis used, but Stephen Lewis got that term from Dr. Akua Benjamin. It's always important to acknowledge the Black people who have been doing this work. So how do we support folks with sickle cell disease, family with sickle cell disease? What we do is we want to make sure that we have a robust donor protocol and process that is not using systemic anti-Black racism to weed out good donors like Black donors. Very briefly, so this man on the left, on your left, Dr. Charles Drew, an African-American man, cisgender man from the United States who came to Canada to study at McGill University. Dr. Charles Drew was an inventor and a scientist, and he created the technology that allowed for our donor systems to exist today in Canada, in the United States, in the United Kingdom. The images that you see in the middle are the posters from the very first public blood donor clinic ever held in Canada, Make a Date with a Wounded Soldier Today. At that time, that public blood donor clinic collected blood for the sole use in military, for military recipients. So if you had somebody in the hospital at that time, you would not have been able to access this blood pool. You would have had to negotiate with the hospital for a different drive. I put these two images together because they exist together. At the time, the Canadian Red Cross Society, which was responsible for, which is the medical military wing of the military, and also created the first blood donor clinic, public blood donor clinic. The American Red Cross Society and the Canadian Red Cross Society, following their neighbors to the south, stated that all the blood collected needed to be ethno-racially cataloged to make sure that white soldiers did not get blood from not white people. Dr. Drew, an African-American man, vigorously argued against that. However, the political will was to keep that unnecessary systemic anti-Black racism and that systemic racism to ensure that white soldiers did not get blood from not white people. Here we see how systemic racism was embedded in the donor system from the very first inception of the donor protocol, right? The image on the far end speaks briefly to some of the activism that happened during the AIDS crisis. At this point, you'll remember that there were groups of people, identities that were identified to say, if you are gay, Haitian, a Haitian person, a hemophiliac, a heroin user, you can't donate blood. That is Haitian community members in New York, and the same protest happened in Montreal, that shut down the Brooklyn Bridge, shut down the stock exchange, and demanded that a scientific, rigorous protocol be put into place instead of focusing on people's identities. And they were able to change some of those practices. Even though there was a tainted blood crisis, understand what came out of the Creever Commission was the acknowledgement that a tainted blood crisis would have happened regardless, and that we should not be blaming that on gay people, Haitian people, people who use heroin, sex workers, that can go on and on. That is not scientific. That is not scientific. And so this piece is what preceded the creation of Canadian Blood Services, but also followed its way into Canadian Blood Services. That's called structural racism. which involves more than just individual prejudices or points of view. It refers to how society condones discriminatory practices and systems of oppression centered around laws, procedures, policies, protocols that codify preferential treatment based on race or racism. So this comes from my research. Again, my PhD is based on this research. I have a funded grant I completed a funded grant that was extended this research. What you see on the right, or on your right, the gay and bisexual men, people generally knew that question, but not as many people knew the questions on the left, focusing people on Africa, whether or not you've had sexual contact with anyone from Africa. And so we move out of the Caribbean and we move to the continent. Again, this was claimed to be based on the science of the day, but in fact was based on systemic anti-Black racism. And this has never been acknowledged by Canadian Blood Services. And part of accountability is acknowledging how the systemic anti-Black racism since 1998 to 2020 to 2023 has worked collectively to keep pushing Black people out of the donor system as opposed to bringing them into the donor system. So this is just a quick excerpt from the donor questionnaire from 1998 to 2005, where it focused on 8 specific African countries. The argument at this point is that there was a particular strain of HIV that did not have a test at that time. And so the only way to make sure that the blood system remained safe was to ban people or indefinitely defer those who came from this region that had a higher presence of this particular strain of HIV. That is the science that is claimed by Canadian Blood Services. However, that science also stated that that particular strain of HIV was present in Belgium, France, Germany, Spain, and the United States. But those questions were not included in the donor questionnaire. In fact, when asked about that, it was suggested by a CBS employee and by Health Canada that it's because the African people left these African countries and went to these European countries and brought that strain with them. That kind of anti-Black, systemic anti-Blackness always suggests that disease comes from Africa to European countries, and that disease doesn't go from European countries to Africa. It is how anti-Blackness works. So if the point at this time was that you could not test for this particular strain of HIV, then why not include all of the countries where that particular strain of HIV was included? And when you read this question, were you born in or lived in Belgium or the United States? Have you had sexual contact with anybody in the United States? Have you had blood products from the United States? You see how ridiculous the question sounds, and you understand that it's not scientific. But when you believe that those questions sounded reasonable when they only focused on African countries, then in that moment, understand that you were buying into systemic anti-Black racism because the questions don't sound reasonable. But instead of removing or changing that question, they instead expanded to read Africa. So when I asked about this, it wasn't, and I said, is it still based on science? The response was, oh no, it's just easier to ask the question in this way. So remember, Canadian Blood Services will say often we base this on science, but then said, we just made it Africa, all 54 countries, where AIDS is not an epidemic, right? AIDS is not an epidemic in all 54 countries of Africa, but it was easier to ask the question in that way. This is how systemic anti-Blackness works. And when I raised this, myself and some community members, with decision makers at Canadian Blood Services, and we identified that this was systemic anti-Black racism, we were laughed out of the room. After that, Canadian Blood Services uploaded these questions to the interactive computer automation. So now when you go, you fill out the computer, right? You touch the forms, you fill this in. When they first tested out that system, sorry, my heart's racing a bit. That's why I'm feeling a little breathy, sounding a little breathy. They added these images for these questions. Now, who does health promotion? Who's been involved in health promotion? Exactly. So when you add images, it is to clarify what the text says. If you add an image, right? Who's on TikTok? When you add an image or when you add something in that way, it's to clarify, to provide further information about what it is that you're asking or what it is that you're educating on. These questions weren't a summer student that was told to Google Africa. These questions were approved throughout all levels of Canadian Blood Services and then ended up on the interactive computer program. There's only one other question at this time that had animals, and that was the questions about the green monkeys. Question that I still think is on the donor questionnaire and actually doesn't need to be asked. But when asked about this, they said, well, we thought it would be nostalgic. Because when you look at this is how people envision Africa. Living close to animals, living in vegetation, living next to dirt, therefore being diseased. This is how systemic anti-Black racism was encapsulated in Canadian Blood Services. And for something Canadian Blood Services has never been accountable for, has never taken accountability of. So anti-African, anti-Black racism would have us believe that disease in Africa and the Caribbean is natural. It is imagined that African people live in dirt, side by animals and vegetation. These are the kinds of images that facilitate Black people being scienced into degradation. And it's important to note that a reliable test for HIV, this particular strain, existed and was approved for use in 2009. However, Canadian Blood Services kept this ban in place until 2015, another 6 years. And CBS will say that the reason why they kept that in place is because Health Canada didn't approve this. And this is where we need to think about what trustworthy leadership looks like. I have a lot more information on my blog. So here are the QR codes, part 1, part 2. I wanted to identify as I wrap up, I know I went through that quickly, I'm so sorry. Here, that's part 2, it'll take you to part 1. The next slide has statements and some reports where organizations like hematologists, like scientists, like Temerity School of Medicine, talk specifically about anti-Black racism. Canadian Blood Services has spoken about systemic racism, but has not specifically spoken about systemic anti-Black racism, nor have they taken accountability for that as far as I'm aware. So as I said, you can't get to an anti-racist system until you address and reckon with anti-Black racism. How do you build trust? The trust Black people have right now, and you'll hear more about this from Dr. Sinat, they trust that Black people trust that when they go to Canadian Blood Services, they'll be turned away. That's the trust that they have. So how do we shift that trust to actually be, no, we want you here. We will treat you respectfully. We'll treat you in a way, and we'll make sure that we are accountable for the harm that we've caused. Quickly, you really want to read Dr. Gaynor Watson-Creed's article in the CMAJ from the special issue, the 2-part special issue on anti-Blackness and Black health on institutional gaslighting. I add this because you'll see a site here. There's a way that institutions like to undermine the work that we're doing. The one I highlighted is, oh, she's just an angry Black woman. She just says these things. These things have been said to me by various decision makers and to many of us in the room who fight for our rights. So we need a culturally safe healthcare system and a culturally safe donor system. Dr. Jean speaks about the work that she's done, and I'm so sorry I'm going to miss that. I do want to quickly say that I've been able to work with these bodies and growing to create the National Coalition Confronting Anti-Black Racism and Donor Protocols. We had a webinar on World Blood Donor Day, which was June 14th, which is on the James R. Johnston Facebook page if you want to watch that. We have created an open letter, which has about 30 to 50 signatures right now for Health Canada, Canadian Blood Services, and Hemo-Quebec, asking them to be accountable for systemic anti-Black racism. You can see our demands here. By building trust, we included the link, Anatomy and Apology, how to make an appropriate apology to Black communities across the country, improving access, which is becoming accountable for anti-Black racism, updating the question about malaria, which I did not even get to. Best practices right now is 3 years, as opposed to an indefinite deferral. Addressing systemic anti-Black racism in the various areas. And then, of course, effective knowledge translation, working with Black anti-racism experts. Sometimes people say systemic racism, but then never speak about anti-Black racism. It's kind of the inverse of all lives matter without actually saying Black lives matter. If you really want to disrupt systemic anti-Black racism, you have to name it publicly, out loud, in your documents. Effective change, provide a detailed outline for how they'll do that. And then, of course, schedule regular meetings with the National Coalition. I was funded by Canadian Blood Services for this project. Please email me if you want more information. And I also want to say, this is where you can find information about the Black Health Education Collaborative. My apologies for in advance. I have to go catch a plane. I am so happy to be here. Please reach out to me. Biba, you are it. You are fierce, you are fire. We met at that CBS meeting, remember? And you've never let me alone since then, and I am thankful. And so for you, I give you my deepest respect, my deepest love. And Jude, you're my brother now, that's it, that's just how that's gonna work. So thank you. I don't know if there's any questions.
We are able to just take 2 questions.
Fine, 2 is fine.
First question, who want to go first? Who want to go first?
I know it's a lot of information. And I went
maybe one question,
yeah.
Quickly. Are you able to see changes from the day you started work on this to today?
Yeah. I've seen some changes. I've heard from more Black people that Canadian Blood Services is reaching out to them. Canadian Blood Services doesn't reach out to me. And so I've just kind of heard it from Black folks. I've met with a lot of Black communities members who are like, how do we strategize around this? And my statement pretty much is the same, that if we are to have systemic change and grow and create generational donors, then the only way to do that, the best practice in doing that is around accountability, not just internally with their own staff, but also as an agency. And we've seen how that accountability has worked in other agencies by taking accountability for systemic anti-Black racism. Some of the kind of obvious ones are removals of the question. For sometimes people think if you just remove the question that the racism has ended, but you can have that for 20+ years and not think that it's not going to have a residual effect. So yes, the questions have been removed, but that's kind of like the most basic thing you can do. But I am really excited about the ways in which Black communities seem to be thinking that there is more will from CBS to increase the number of Black donors, but collectively they have acknowledged that they still haven't seen an accountability around systemic anti-Black racism. So I think in this work, it's like a yes and a no. Yes, there's some things here. Yes, there's some things that are still outstanding.
Okay, thank you for this excellent presentation. And I think it'd be so important for hematologists and healthcare providers to hear more of this. So thank you. And I was just wondering, are there other jurisdictions we can learn from who've been successful at making these changes? Mm-hmm. Perhaps like in Europe or the United States, I don't know.
Yeah. You know, it was my US, you know, it works differently in the US. Blood systems are differently, blood product systems were different in the US. But whenever I presented this in the US, especially when these questions were still live, folks in the US were like, these questions aren't happening here. So what is going on? And then when I was speaking with researchers in Togo and Cameroon and Ghana, they had some really great questions on their donor questionnaire. But the African continent seems to be a place that Canadian Blood Services, Hemo Quebec don't go to for best practices. So they'll go to Australia, New Zealand, the United States, but they seem to think that that huge, big continent in the middle is not a place where you can get information. But what I'm finding there is the work around HIV and therefore the work around blood donation and the work around malaria. They've created some really vibrant and excellent donor questionnaires. And that information is lacking and missing in this context.
I'm really sorry because we have to go. Please help us. Thank you again. Biba, can you come? Biba, can you come to introduce Alvin? Oh, Biba, I will do it because we.
So, hello everyone. You are going to meet a warrior, my friend. Sometimes we love each other. Sometimes we love each other less. Sometimes we fight. Sometimes we agree. And when Alvin calls me and says, Miss Biba, I love it. I love what you did. And I know I'm on the right path. Because he's the ultimate warrior. I want you to listen to him carefully. If you want to know about what living with sickle cell disease is, you've heard Ulysse Guerrier, listen to Alvin. Friend.
First of all, I'm gonna complain that Ulysse got like 20 minutes and I've been told I got 5 minutes and already started from the walk up. So I'll do my best. And as Miss Biba said, and I call her Miss Biba. Sorry, for those who understand, you call her Miss Biba or nothing at all. I'm a warrior, and I will leave it at that. An old warrior, even though I don't look it. So I'll just start off, 2 fake hips, a fake shoulder, laparoscopic cholecystectomy, liver failure by the time I was 19, revision in 2014, and a 3 by 3 centimeter hole in my left ilium crest. Those are for the doctors. ACS, acute chest syndrome. Sorry, I gotta remember that. Not everybody here understands the language. Acute chest syndrome at least 30 times. I'm running through it like that because my speech was supposed to be about what it's like to live like that and what the daily life is like. I was lucky that I had parents who decided that the best thing for you to do is to understand your disease, and everything was a choice. So when Alvin was a Boy Scout, yes, I know that ages me a little bit. There was a thing called the winter gold camping badge, which meant you had to spend approximately 48 to 72 hours in Algonquin Park in February in a tent. And as soon as I completed my winter gold camping badge, I spent 6 months in sick kids with ACS and pneumonia like you wouldn't believe. But that's when you're young. When you get older and you make it into the workforce and you hear wonderful words now, like work-life balance. So to give you an idea of how old I am, I started working at the Bank of Montreal co-op during Comp Sci in 1996. So yes, I am that old. There was no such thing as work-life balance. And so to be getting sick every single month for about anywhere from 2 weeks to 3 weeks at a time, not every month by that point. That point, it was like probably like 3 to 4 times a year. You're getting sick 2 to 3 times a year, and you're missing 2 to 3 weeks each time, plus a week after that, because you're not just leaving the hospital one day and being back to work the next day. That's not happening, right? I was lucky. I consider myself lucky that at one point in 2009, I was working for a great company. I got sick and they were like, listen, if you want to do this little thing over here on the side, as long as you keep the clients with us, you can do so. So I've been self-employed since 2009, 2010. But what does that look like for somebody who's not as lucky as me? or who's going to school like I did, and it took an extra year to finish school because you're sick, right? Like that's a regular thing for us, getting sick, missing time someplace, and not being able to get it back. But then you hear like these wonderful words, work-life balance, and it's okay, we understand. But then a month later, we're gonna have to let you go. You've missed too much time. My best experience, I will not tell you who the company is. For all of you, most of my experiences have been with the financial institutes, so I'm not naming the company, but you know where it is. Did the 3 months of training that you needed, but it was still under probation. I got sick the last week of probation. They brought my stuff to the hospital room. I did not make it through probation because of getting sick the last week of probation. That is regular in my world, right? You get sick, and if you're lucky enough, the company will ride with you. But how long do they ride with you? How many of them are really understanding? And especially in this turnaround age of where like 1 minute you're working for one manager who seems to be cool, and you get to another manager who's absolutely not cool. And everything is about productivity. So as much as they say work-life balance, we need a body in that seat doing this job. And if you're not able to do that long enough, we're gonna let you go. That's one aspect. Now try having a relationship. So at this point, I'm single. Miss Biba is still trying to marry me off. It's never gonna happen. No, don't clap. Don't clap. I am picky beyond picky. And at the same time, I no longer trust. I no longer trust because I've heard things like, I can't handle this anymore. And the first time that I realized that it doesn't just affect us, even though, of course, I'm the one on the bed in pain on a lot of things when my liver failed. And I ended up in a coma for 4 days, and I was in the Toronto General Emergency Transplant Step-Down Unit. And I woke up 4 days later, and my mom, who was a certain age when I went to sleep, was 10 years older when I woke up. And that's when I realized that my life affects other people. But I've had partners tell me they can't do it. They can't do it. They can't watch me like this. They can't be there for that. They need more. I've had dads say to their daughter, how's he going to support you? Do you really want to spend your life taking care of him? I don't know. And it wasn't until I got older that I realized. So what I used to say, so from a very young age, I knew I didn't want to have kids, or so I thought when I was 11. Because I in my brain, again, my parents were like, learn as much about the disease as you can. So I can have SS, partner with an AA, that child has AS, but then they meet another AS, and boom, I can have a grandchild with SS. And I was like, no. That got tested when I was in late 20s, early 30s, and a partner I was with wanted another child. She already had one. She wanted another one. Found out men with sickle cell have low sperm counts. And I'm not going to say that it was the drug that I was taking at the time that caused that to then be permanent. So I'm unable to have a child because of the medications that I've been on. Miss Biba has also asked me to bring about like the mental health aspect of that. It can break you. It can break you to be in your mid-20s when everybody else is starting to get married, have children, live their life, and you're celebrating your birthday once again in the hospital because my birthday is at the end of the year. So it's, closer to winter. And you know what doesn't do well in the wintertime? People living with sickle cell. Just, it's not a good thing. You then are losing jobs. you're losing partners, right? And you're adamant that you want to do it on your own. You don't want to live at home, because I have family relatives who think my parents are absolutely crazy for allowing me to live on my own. And to give you a perfect example of a fight that Miss Biba and I just had is, so I had a foot ulcer number 6, it was. And being Alvin, I just ignored it. I was like, add it to the list. Pain, I don't even know what that word means. I think it's something that people talk about. I now use words like discomfort, right? And I'm not feeling the greatest. Miss Biba actually starts off the thing with, she knows not to ask me how I'm doing. She says, what's your status update? And then I give her a real answer. But the fight was, I got like really sick. Turns out I had COVID. It was Ulysses who found out that I had COVID, because he came over and he's like, listen, dude, all you got to do is take this little stupid test. And I'm like, right? But I had a fever of 104 for a couple days. And my mom thought that the ulcer had gotten so bad that it had poisoned me and I needed to be in the ER. Every single time I spoke to a doctor, they were like, you're not getting any antibiotics from us. My mom, of course, she was like, don't you need a third opinion? No. So me and my delirium Biba called me in the morning and she was just like, oh, what's going on? I was like, oh, Miss Biba, I'm not well. Talk to my mom. Never do that. Never, ever, ever tell Biba to call your mom. So my mom comes over on the Monday and she's like, we're here to take you to the hospital. But of course, by that time, the fever had broken. I was well. But Miss Biba calls in and she's like, oh, I called, I'm going to mention a doctor's name here. I called a certain doctor. You know what? I can't do that because I realized his coworker's in the back of the room. Biba called that doctor because my mom was worried about me having blood poisoning because of the ulcer. In the end, it was just COVID. But those are the kind of fights that we have, and that's the kind of life we live, because people worry the minute you live alone. They're like, you don't have a partner. And I got mad at Miss Biba and my mom. I'm like, you wouldn't do this if I had a partner. And both of them were like, yes, you're right, we wouldn't. And so stop it. Sorry, the other person clapping is also that was involved in that situation too. You're right, I don't. But that leads perfectly into the collaboration and why we also need things like the registry, right? I'm lucky that not only am I well-versed in my disease and I know my body inside and out. And what changed it for me was yoga and acupuncture, something I fought for years because I was very scientific. I was always like, how is yoga gonna change is it gonna change my sickle cells back into normal blood cells, and acupuncture is not gonna do this and acupuncture is not gonna do that. If I could go back and talk to 20-year-old Alvin right now, I'd be like, get to that yoga studio now. The collaboration that happens between the organizations is something that is a must, and we should all look forward to making them stronger. And when I say organizations, I don't just mean the SCDAC with the SCAO or the Sickle Cell Circle of Manitoba or a Foundation of Alberta. I'm also talking about the ICBH, UHN, Sick Kids, the Ministry of Health. All of that collaboration is needed, so that way we can finally find a cure. When Dr. Pat, I don't want to ruin your name or say it incorrectly, when she said there was a cure for CF, I was at the back of the room, literally using language that's inappropriate for any recording, being like, how? Right? There's a miracle pill. How? We are the world's oldest and most prevalent genetic disorder. And I'll say it, the reason there's a cure for CF that has less people affected by it than sickle cell, right? There's a reason why they have, like, the sickle. Also as a patient, I'm also part of the Sickle Cell Association of Ontario as a board member. And I could tell you that what CF brings in donations would be, if you collected every single group in Canada, we don't make 10% of what CF gets in just Ontario. And that's collecting them all. And we all know why. We all know why, because it doesn't affect a specific set of people, right? I'm trying to be as politically correct as I can. With all that being said, and also to make sure that I stay on time, if you guys didn't hear what Ms. Bieber just said, she said I'm already over time. We need to collaborate better. We need the registry. The registry allows us, everybody's come up here and said 5,000, 6,000. I believe the real number of affected people living with sickle cell in Canada is 10,000. Ulyssa and I are very sure that if you were able to really get into it, and I'm pretty sure the doctors know, like they have our blood work. I bet you if you were to get, it's closer to 10,000 people living with this disease in Canada. And I might happen to be on hydroxyurea, and some other people might happen to be using blood transfusions. But some of these new drugs that are coming out are definitely needed here in Canada for those reasons, because some of us don't respond well to blood transfusions. That would be me. Some of us don't respond well to hydroxyurea. So then what are their choices then if they don't respond well to either of those two drugs? And hydroxyurea was not created with sickle cell in mind. It was a cancer drug that had some benefits for people with sickle cell. And blood transfusions is blood transfusions. We can go back to the days of bleeding a patient, right? That's all it is. But to end, consider the fact that when you see someone who none of you would have guessed what's going on the inside of this body, since you probably see me around anyway, that it's affecting us and our families in so many different ways, and we need all of your help. Every single person in this room, we are here to raise awareness. Do not be shy about it. And the shy about it part, I'm speaking directly to my community. We need to end the stigma, and Ms. Biba gave me a new word that she heard in a conference somewhere recently, and I'm going to use it before her, stignorance, right? Stignorance. Let us end the stignorance about sickle cell. Thank you.
I think we need another birth time, and Luancy will sing "A Change Gonna Come," and I think it is really the song we need now. And right after, we'll have the last panel.
Oh, okay.
I was born by the river in a little tent, and just like the river, I've been running ever since. It's been a long time.
Okay, so we will proceed to the last panel, and we will be very strict with time. So I invite the guests to come along on the platform. Ok, donc Jude Maricena et Bibatenga vont venir. Et Dr. Walrond as well, please. Okay, so we will first hear from Biba and then from Dr. Jean Walrond after.
Okay. Hello, everyone again. So I'm going to talk about a project that we did recently, a project that I'm very proud of. It started with us as patient group engaging the blood operator, both in Ontario and in other provinces like Alberta, Manitoba, everywhere, making sure, but not Quebec, because Quebec is just Quebec. And then there is our Quebec group working with them directly. So we were engaging them, talking about blood, the need for blood for the treatment of sickle cell disease. And one of the things that we couldn't understand is that the donor base is so small, and we know that our community needs the blood to survive. You've heard it from people today, from the physicians, from the patients. And as we were working, then we decided to look, because I keep telling them, I don't understand. We Black people are about collectivity. So we talk, we go to churches, we go to mosques, we go to community events, we talk to our people, and they usually show up for us. But then the donor base is so small. So we don't understand, something is wrong. So that's when they said, okay, let's work together, people, let's look at the barriers. So that's why CBS brought some of its researchers. One of them, a wonderful woman by the name of Jenny Howe. She's not here today because she's attending a conference in Sweden. We initiated, and then it came also with the work that was started in Alberta by Dr. Jean Walrond, who started to look into these barriers. So we initiated a collaborative community-based project, the first one in the sickle cell community. First of all, I have to tell you about Sickle Cell Disease Association of Canada, who we are. It's the national umbrella for sickle cell disease. SCDAC was founded in 2012 when we realized that there was a need to advocate at the federal level for some of the issues that we were facing. Organizations like the one in Alberta, the one in Quebec, and in Ontario were already in existence when SCDAC was founded. And wherever you see the red, that's where we have representation and we have member groups. So our goal is to just turn this map red and have a group everywhere working with us collaboratively. They are independent in their own process. They are independent, but they come to us and we set common priorities and we work together. I'm not going to tell you what SCD is. You all know what sickle cell disease is. But our mission is to be the national voice for sickle cell disease, and we advocate for the 6,000. Again, you've heard the numbers: 6,000, 5,000, 10,000. We don't know because we don't have a registry. So we advocate for newborn screening. When we started in 2012, just a few provinces were screening for sickle cell. Now we only have 2 provinces not screening: Saskatchewan and Manitoba, and we're working on it. They will do it. Everyone is going to start screening for sickle cell disease very soon. And then comprehensive care, you've heard it also, better access to care and more research, for sickle cell disease. You've heard about the population affected, right? So it makes sense that sometimes some people will say, I've never heard about sickle cell. But for over 40 years, we've been left with supportive care. I said it before, and I'm repeating it, and we've heard it from Ulysse, from Alvin. The state of the care for sickle cell disease is not the best in Canada. We need a basket of options to treat a multi-system disease. It doesn't make sense to have just 2 options for a disease that affects your entire bodies. And again, life expectancy is very short. But again, we can demonstrate it. We have 10,000 stories. I can bring so many patients and caregivers to share stories. But if we don't have a registry, we cannot really use the type of data that we can use to go meet our policymakers, our government, and tell them, here is the quality of the care, and here is exactly what the life expectancy is in Canada. So before I go into that, I'm going to share a very personal story of how I became this health advocate. My son was born in Nigeria, in sub-Saharan Africa. I like to say that we were at the door of the Sahara Desert. When he was born, he was a normal baby, and then he got sick around 6 months for fever. We thought it was malaria. Then we went back after 2 weeks, treatment didn't work. And then they said, well, he had yellow eyes, swollen fingers. Then that's when they said, maybe it's sickle cell. So we got the diagnosis when he was about 7 months. But when I got that diagnosis, it was a death sentence. They did tell me specifically that he wasn't going to live. I will be lucky if he lives to be 5 or maximum 15 years old. That's what I got. And guess what? There was no mental health support. There was no thing. The doctor tells you point blank, you go home with your child. No internet. I had no medical background, no clear understanding of the language that they were using, no support. That's what was handed to me. This writing that you see is the actual writing of his physician. He wrote the blood type. He said, this is very important. You need to always know that. And then you can see his hemoglobin S was already 62.9. And he told me that F, which is the fetal hemoglobin, might change at some point and become either an S or an A. But in his case, it didn't turn to be an A, which is the good one. So what treatment option did we have at the time? It was blood transfusion every time we went to the hospital, hydration, because it's very hot and warriors have to hydrate, and painkillers. That's all. And I thought, well, it's normal. That's what we have here, right? And we kept that boy alive just by doing what the physician told us to do, sheltering him a lot, immunization, and blood when we needed it. But a few years in, all the time, I will see that the physician will give me this specific paper and tell me, Biba, I want you to go and take this test and bring me the result. The system is different. They hand it to you, you go get the test, and you bring back the result. And one day I was wondering, what is serology complex? In English, it would be complex serology. So I had friends who were in med school, maybe year 1 or 2. I went to them to say, what does this mean? They said, well, Biba, this is for another disease. They're testing for AIDS. I'm like, what? And you see the date? It was in 1992. He was a little boy. And I said, well, what's that? They go, this is worse than sickle cell. If he gets this one, he will die for sure, Biba. And I told them, I said, but how can I stop that? How can I prevent that? Because there is nothing you can do. That means he doesn't trust the blood he's giving your child. So every 3 months, he was testing for AIDS. And if he gets the AIDS, he will die. And if you don't give him the blood, he will die. So that's what it is. That's how I raised this boy. So when I stand today and say that we need blood, and I understand the need for blood for sickle cell, it didn't start in Canada. And at the time, the head nurse came to me and said, well, Biba, I think your son, we know which type of crisis he has. He has sickle cell anemia. He's gonna need blood for the rest of his life. But here is the problem. We might not always have the blood he needs. So we have a deal with families. You go into your community, you get people to donate blood regardless of the blood type. And in exchange, we will keep the equivalent for your son because sickle cell crises are unpredictable. I was 19 years old and I was recruiting blood donors in Africa. Everybody I said, if you are strong, you look healthy, I will ask you, can you donate blood? When my friends were partying at 19 years old, I was recruiting blood donors. That's how we handled this boy, and we decided not to give him blood unless we had no choice. And by the way, do you know my son? He's in the room today. He's gonna hate me for this. Ismail, can you stand up? So that created fear, distrust, mistrust. And those are the same things that I found in North America when I came. We immigrated to Canada. He was about 15 years old. They told me that maybe he might, die. So we got there, he was just 15 with a 3 years growth delay. But a miracle happened here. The physician at St. Justine said, we can help him grow up with blood. And yes, they did. They gave him blood every single month for a year. And the man grew up like a mushroom. I'm telling you, the miracle of blood, it happened under our very eyes. But then it created other problems, iron overload. He spent years on medication for that. We were part of the first people to be offered the clinical trials for XJADE when it came to Canada. And that's why I understand all the risk you take to get new drugs to Canada. By the way, as we advocate for the new drugs, they will not come because you want them. They will come when our community sits in the clinical trials, get the Canadian data that we can take to Health Canada, and then we can bring those drugs here. So that's why we have to be prepared. That's life today for him, and that's him. I know you hate this picture, but it is here. He goes to the hospital every 6 to 7 weeks. We need about 9 to 10 pints of blood, and it's still painkillers, antibiotics, and blood transfusion. Hydroxyurea did work for him for 3 years, but then it stopped working. So now the only option left for him is the blood. So I understand it. And I've seen him have a reaction to blood transfusion. I've seen him go through the crisis of the Sutherland shake. It's scary. You don't want to experience that. It's a trauma that you can't forget as a parent. So that's where I come from. And when I advocate, when parents come and we go to the health operator, we understand that how important is it for the blood to be safe for everybody, not only for our community. We understand that. But what we are advocating for is to make sure that barriers are removed so that people who can donate blood do so that we can save the lives of our family members. So we need more African donors, to come to CBS and HEMA Quebec to donate blood. In Quebec, there is a great success done by Mr. Wilson Sanon because he was able to get HEMA Quebec to go on Sundays into churches where our community is, and they're donating blood. CBS is not doing it yet. They are not really present in the community. But let me tell you something. With the work we are doing together, I see change. It has started. Because even the materials they are proposing is changing now. And this collaborative project helped us create a tool. As you can see here, these are the Felix brothers, and their dad is here. 3 brothers, 2 of them have sickle cell disease. They live here in Ottawa. They're already blood recipients. So look at the young generation. They're gonna need it for the rest of their life. So we can't afford to sit here and continue to have a very small pool of donors. My own son is linked to about 10 people in his life that we know nothing about. I'm very grateful for the gift of life. But every single time I wake up as a mother, and I'm scared that what will happen to him if one of them moved out of Canada or decide to stop donating blood, or something happened to them, they get sick and they can't donate blood. What is gonna happen to my child? That is a scary thought for any parent to live with. So this is why we sat with the blood operator and we did this project in collaboration with the community, and we look at the barriers. But what we did here, we look at the materials that was given in the community to recruit blood donors, why it wasn't working. I have to make a pause. Do we have Dr. Howe's presentations? Do we? We don't. Jenny. So the part where we present really the method and the work that was done was recorded by Dr. Jenny Howe, but she's away and apparently they don't have it here, so we can't play it. But I'm just gonna show you the recommendation quickly. This is what came out of the work that we've done. Be transparent about deferral criteria, because when you go in the communities to recruit blood, tell them that those who have had malaria can never donate blood. Don't let people come and get deferred and then they live with this rejection feeling and we can't get them back. And what happens is that the word is spread through the community and others are not gonna show up also to donate blood. You know, conduct research to ensure that the deferral criteria are minimally restrictive while maintaining safety. We have, that Dr. Drayden mentioned, we need more research, you know, and then also show the process to people because they don't know how, if it's painful, how it can affect their health, how long it takes. And they mentioned that, you know what, it's also financial. Some people don't have the time to take maybe the afternoon to go and donate blood. So that's why when you come to them after church, for example, on Sundays, they do have time to donate blood. Or if you drive to their communities where they live, because it's far from downtown, maybe they will donate blood. So have a presence in the neighborhood, you know, be visible. We don't see CBS in our communities. We don't see people who look like us in the ad, but it's changing though, it's changing. We've had a video from Ulysse, and then now there's a new picture with Andy, who is from has sickle cell. I've heard that people saw something in Scarborough, in Toronto, with Andy's picture, and they've been calling me and telling me about it. So change is coming. Now, these are the work that's Andy right there with the red shirt. And we published an article in Transfusion, and we presented a poster at the conference. And now the tool that we've created is here. This is a recruitment guide that we want people who are recruiting blood donors to use when they go into Black communities, especially racialized communities, because it came from the people who are potential donors or donors themselves who told us what they like or didn't like. So CBS has launched also a website where specifically dedicated to sickle cell. We are going to share it through our social media today, right, as I sit here. And I want you guys to go. That guide is uploaded there. You can download it. We've also gonna have some printed copies available. Send an email, we can send you. But that page is good. If people want to donate blood, tell them to go there and read. If you recruit them to donate blood for sickle cell, tell them that. And one last thing that we've done, when I became leader in this community, we gave every single province the PFL number. And the PFL number is Partner for Life number, so that every province in Canada, sickle cell group has their own numbers. And what it does is that if you register on blood.ca and you donate blood, that donation is attributed to sickle cell disease. First of all, it shows CBS how willing we are to work with them, you know, and make sure that we remove, but also it tells us that people are listening to us and our efforts, you know, are being, you know, done. So they're asking me to conclude, and I've been doing that to Alvin, so I have to keep quiet. So thank you so much for your time. And I hope that those who can donate blood here will, when they leave this room, or they will recruit blood donors for us. Thank you.
Okay, can you all hear me? Yeah, okay. Good afternoon, everyone. And I am here to present to you. My topic is called The Future is Bright for Research in Sickle Cell Anemia Disorders, but Nothing About Us Without Us. I speak to you today as someone who has Carib ancestry. So I am indigenous to Trinidad and Tobago. I also speak to you today because the indigenous people come from South America, the Caribbean, Central America, the United States, and Turtle Island. I also speak to you today because I celebrate Juneteenth. So happy Juneteenth to everyone. And this goes back to the fact that my genes, my African genes, survived the Middle Passage. So this is why I'm here speaking to you today. I stand before you today as a sickle cell parent with a PhD in education policy studies, where I focus on culture. I looked at culture with respect to Caribbean students who attended school in Edmonton, Alberta. I have been able to use that degree and transfer that knowledge to looking at sickle cell anemia as a health disorder with respect to how health is taken up in different cultures. So I am now the subject matter expert for sickle cell anemia disorder, cultural and social policies.
Can I do it for you? Just say next.
Thank you. Thank you. I am standing here today, and I'm just leave it on that slide there. I'm standing here today to put forward and to lobby the government of Canada to give us $25 million to conduct sickle cell anemia disorders research and sickle cell anemia trait. Here's why. If you look at that slide there, it talks about a cultural identity model. This is the model that I developed when I was looking at Caribbean Canadian students and how their education, their culture is taken up in the school. If you look at this model, you will notice that what happens here is that the culture is taken and put into the outermost concentric circle. This is because culture is represented in each and every sector of our society, our community, and the different realms that we are not aware of today. So culture is part of it. You can take it out and see that I have positioned myself in the center, and then at the bottom, you can see a sort of a black circle. That is because this is just a plain XY diagram here, but that black circle at the bottom represents all different people and how their culture is represented. So the different people in that sphere, those who have gone, those who are present today, and those who are yet to come, influences my cultural identity, and so do yours. So this is what I used. Now, if you can think about it, most people look at culture in the classroom, but think about culture with respect to the healthcare system. If you are not very familiar with it, you have a very relaxed quasi interpretation of it. You will definitely not engage in that medical structure as others who are more used to it, more attuned to it. So the hypothesis is positive outcomes occur when individuals feel that they are welcome in a specific structural environment. Next slide. Okay, so the other problem I had was recently I was asked to do a proposal for funding. And what I was asked to write about is nothing about us without us. I had to comment on that in my proposal. It turns out that this concept was taken up by people who were mobile, restricted, and so on. They wanted to be part of the discussion when anything is done about them. They wanted a place at the table. Oops, sorry. So, in asking for this $25 million, I think I have a right to do so, and here is why. Can you please go to slide? Keep going and I'll tell you when to stop. You're too far gone. Okay, okay. Bieber, I think the slide is slide 6. 6? No. Is it this one? Yes, thank you. Now, if you look at this slide, I know earlier this morning, someone spoke about the first person who looked at sickle cell anemia. What happened was that the young man came to Chicago to study dentistry. It was determined that he had sickle cell anemia, but that is not how it came about. The young man's name was Walter Clement Noel. He came from Grenada, and he lived from 1884 to 1916. Ernest Irons, who was an intern at the time, kept copious notes about this sickle cell patient, thus giving enough information to James Herrick so for him to discover in 1910 the sickle cell disorder. Linus Pauling called sickle cell anemia the first molecular disease. And that molecule is part of our DNA. The molecule is found in, the errant molecule is found on chromosome number 11. So we look now at the discovery of dioxyribonic acid. This gentleman, Mercier, he discovered that human pus produced a precipitate in an acid solution and in a basic solution, and in an acid solution, it dissolved. Now, the thing about it was that he started to look at it, with lots of curiosity. But he did not get very far with it. The properties that he found, he wanted to do more information about it, and he found that the properties were parts of other proteins. And the pure form, he called it nuclein, and this is coccyl. So when we hear a lot now about DNA, we also hear about RNA. So I explained this to my grandson, who is 8 years old. And I said to him, this is what a motif for DNA looks like. And when you pull it apart, this is RNA, RNA. When you bring it together, it's a motif. So it spins on both ends. So he said to me, oh, the DNA helix. And I said, yes, that's how you understand it. Now, Crick and Watson were the ones who named that double helix DNA. If you notice my diagram here, you would see that the chap from Grenada, we don't have a picture of him. Now, the unit of your DNA is now called a gene. The Human Genome Project started in 1990. What they used were blood samples from Buffalo, New York. And I understand that the person that they looked at was African-American and white. they came up with the mapping of the DNA, your genes. I call it the alphabet for your genetic structure. But there were some gaps in it. And the Ptolemaic to Ptolemaic consortium filled those gaps by March 31st, 2022. Leo said, well, this is a single genome, a project based on a single genome. What about the multiplicity of different people on our genetic diversity? So now they suggested now we talk about a pan-genomic hypothesis in which 47 humanoids will be looked at globally to really fill out this alphabet. They are going to get the majority of those 47 people from the African continent. There is more variation in your DNA within the African continent than between people from the African continent and the rest of the world. Today, we have organizations such as Evitas, I hope I'm getting their pronunciation properly, looking at CASPR-Cas12 in doing sickle cell research. Yet we hear so very little about what other research that can be taken up. We have heard everybody stand up here today and speak about a lack of funding. Now, we have contributed the basic molecule for looking at your genetic makeup in order to determine what is possible. One molecule breakdown on your chromosome 11 is responsible for sickle cell anemia. I love maths. And if you have one variable that you're looking at, you can do a substantial amount of research rather than looking at 10 and 12 markers on your DNA, which they are doing now. I want you all to go and check and see how many markers on your DNA contribute to cystic fibrosis, how many contribute to cancer. If we are contributing that much knowledge to genetics today, isn't it time that we demand $25 to $30 million to start doing research? In Canada, I found out from reliable sources that in the United States, they are looking for $500 million. When I contact people at a certain company that made Oxbryta in the States, I contacted them to ask them, how come your medication is not up here? They said, well, we need to get approval. And I said, and how come we cannot even see it on American channels? From the border, they cannot advertise it because it is restricted in Canada. So what are we going to do? Well, I'll tell you what we did with respect to sickle cell anemia in Alberta. During my reign as president, we got newborn screening for Alberta and Northwest Territories. Can you flip your slides now to one? What? No, forward. You just passed it.
Oh. This one?
No. That one. Okay, if you look at that slide, it says that Sickle Cell Foundation of Alberta created an K-12 curriculum for African and Caribbean Canadian books. It is an award-winning compendium, and it is in our library system. What we will eventually do is link K to adult sickle cell books, fiction and non-fiction books, and we are going to develop an app so we can have those books loaned out worldwide and take them back in due course so that everyone worldwide will have information about sickle cell, so we would not have these phobias because we're going to be educating them. The next thing we did, Biba mentioned the research that we did. We decided that we would have mixed methods research because I advocated to Canadian Blood Services year after year, and they didn't listen to me. So I went out and I got the funds. We did the quantitative part of that research. We looked at 110 individuals in our community of Edmonton. We found out that people did not know much about sickle cell and they didn't know much about blood donation, but they told me that they got their information from social media. So what we did, we developed an app. We developed an app so that we could get people to donate blood. This app now is already developed and it has to be brought into the public domain. It's called Misha's Fine Size app. The next thing that we have done is we have set up a legacy fund for creating a research chair at the University of Alberta for studying sickle cell anemia. I also work with sickle cell groups in the United States, and we have 2 projects coming up as I speak. The first is a faith-based initiative because we are going to go to all the faith-based communities across Canada and get them involved. We are going to be talking to the Centre for Disease Control and getting the protocols on how we go about telling people to promote sickle cell anemia through their churches. We are also going to look at a post-secondary based initiative, and that initiative is going to be focusing on the historically Black universities and colleges across the United States, their fraternities and their sororities. And we are also going to be going across Canada, looking at all post-secondary schools, and we are going to be having them, the Black campuses, involved in spreading our word. If anybody wants to hear more about what we're doing, that's my address and that's my email.
And I know you are tired, so I will take less time.
Thank you all for sticking with us.
Yeah. And yeah, I touched on my presentation on understanding systemic racial barriers to blood donation among Black people in Canada. But I found this part important to put. It is a station farm interviews we did. Our blood is not pure enough. Where's the? Yeah. So. Okay. So there are really 3 main motivations we have doing this research. The first one is the fact that we received a lot of emails from people from the Black communities asking questions about different things, but also how the center will address this kind of aspects. One of them is someone who said we have to do something to stop them treating us like animals with impure blood when we want to give blood. How can you accept being told that because you are Black, because you spend your childhood in the Caribbean, you can't give blood, your children won't be able to give blood, your grandchildren won't be able to give blood? Does it take 3 generations to purify our blood? But also the second motivation is the fact that we are doing that work with Sickle Cell Disease Association of Canada, but also because we were approached by CBS, Canadian Blood Services, to try to see how we can address barriers related to blood donation within the Black communities. And this, it was impossible for now to work with them because we don't want to legitimate anti-Black racism. And it was the kind the work is doing is not like the center, the leadership and scientific committee of the center had meeting, and we found it is not the way to go. We had a qualitative method, but we are at the beginning of analyzing the data. So what I will present today is really preliminary results. And the barriers we found, the first one is financial barriers. People who said like, I have 2 jobs comparatively to my colleagues. I'm underpaid. It is difficult to dedicate time to give blood. So I think it is one of the things which is important, but also we can remark about systemic racism when people said they are unpaid, and we know Black people are unpaid in Canada for the same job compared to white people. But also anti-Black racism, and people will say, my brother who lives in the US donates blood. In Toronto, they say I can't give blood because I'm Black and I come from a Black country. And I will say some words about this because in the Wednesday workshop, we had a question from someone from CBS, and I want to answer to that question. And people say, you experience so much racism that you are afraid to give blood. The blood of many Black people has been refused because of racism. And even when it's the norm, the way it's said, you feel you are impure. So another thing is institutional and systemic racial discrimination against Black people in the healthcare system. And I think that part is important. Even, for example, one of other things we found was the lack of confidence. And I want to take this citation, someone who said, during my delivery, I almost died because I wasn't respected by the health system. So why should I trust giving blood to people who don't respect me, who treat me with disdain and discrimination? So the racial discrimination in the healthcare system also impact the blood donation within the Black communities. But also there are religious aspects we have to try to study and try to better to examine and to better understand. But a lack of information, accessibility of blood donation centers, and I think the religious communities, they have a great role to play on this. In Montreal, for example, you have a lot of churches and they organize blood donation, and I think that works. But also prejudice and stigma in the Black communities about blood donation. People would think, like, for example, oh, I'm too sick, too weak to give blood, and giving blood, maybe I will be sick. And one of the things which was people talked a lot about was the belief that Black people's blood isn't really used by CBS and Quebec. And a lot of people said, oh, like one of the things, like it is like things from people who were interviewed, and they said, oh, that's from someone who worked with for CBS. Like someone who worked at the Canadian Blood Services told us, the blood of Black people is just for testing. They never give our blood to people. It's not worth giving blood as a Black person. So I think all of that barriers, we have to understand them and to know what are the impacts on blood donation in the Black communities. One of the things, and that I experienced it myself, and my wife experienced it also, like the lack of skill in injecting Black people. Like people said they prick us many times. We don't trust their skills. Like they try to prick you, and many times, and they cannot find your vein. And it is something that is real for Black people. Myself, I experienced it, and my wife during the two deliveries, the delivery of our two babies, experienced it also. And also lack of representation in the healthcare system, and also in CBS and in Quebec. And a lot of people said, oh, we were in the blood donation center, we are the only Black people. And there was no Black nurses, and we were the only Black people. And I think all of this can help to understand this. I wanted to say some word on the malaria issue, because it was the question by the CBS person. First of all, to know, it is the current risk in the US or in France is 1 out of 4 million for transfusion-transmitted malaria. 1 out of 4 million. For AIDS, even with the test, it is 1 out of 1 million. Yes, it is science. What I'm saying, it is about science, about that data. And in the US, England, Australia, France, if you have a history of malaria, you can donate blood. In Canada, you can't. Even the FDA, which is a well-known racist institution, and I'm I'm an Asian citizen, and I can tell you about FDA and how they were racist against Asian people. And even them, they took action to let people with history of malaria give blood, but not CBS and Quebec. And I think it is very important to know this. And why we decided to do not participate in the CBS action consultation on this, it is because we discovered that CBS has data to take the right decision. They published they are from CBS. They published an article in 2019, and in that article, they explain about France, Australia, England, and the US, and also Canada, and they explain the situation, they explain the policies, and they also explain all the data and evidence about the data, and why it is important to take action to remove like the permanent deferral, like you cannot give blood if you have a history of malaria. And in that article also, one of the things they show was the key factors in decision making for the US. Now the 3-year deferral, and for France, if you have a history of malaria, to test you for malaria. And they said it is like what motivates the decision is like the permanent deferral is political concern and regulatory concern. But we don't know that political concern, and we want to know what they are. And I think it is important. We also found a community suggested solutions, but I think I will take about them another time. But what I want to conclude with, because first of all, I'm a clinician psychologist, and a lot of people who tried to give blood, to donate blood, they also spoke about mental health issues when they faced like the barriers, and people who said, by phone, you will not be able to give blood. Your children will not be able to give blood. Your grandchildren will not be able to give blood by CBS because they are born in a country where malaria is endemic, or because they have an history of malaria. That people, they feel like they are very affected psychologically by this kind of declaration, of statement. But also, I want to note that the mental health of people with sickle cell disease in Canada, and I think the fact that for now we have no study, like when I say no study on this kind of aspect, and I think it is important to have more research on this, and to also think like it is not, we are talking about this, it is not because, I don't know, in the room today, a lot of people spoke about cystic fibrosis and sickle cell disease. And we never say the word, it is about skin color. And it is important to name it. It is about racism. If people with sickle cell disease were like, if they were predominantly white, I'm sure we'll have funding for research, we will have a registry, and we'll have medication to treat it. Thank you.
Thank you, everyone. We're really at the end of the day, but I would like to call Judy Grandison just for 1 minute, 2 minutes. Judy is the mother. She comes from Toronto. She has a teenager boy who lives with sickle cell disease. She is the president of the camp Jimoke. Camp Jimoke, she will tell you just about it because she wants people to know about the camp.
And I think after we'll take 2 questions and then.
Good afternoon, everybody. I actually was trying to leave about 20 minutes ago, and I got B-Bud, the same kind of treatment that Alvin got. She said, no, sit and stay. She wanted to make sure that I was able to speak to you today. So B-Bud, we're turning it into a verb now.
Oh my God.
Before I talk about camp, I just wanted to share one little thing. In 2006, I was pregnant with my son. He's now 16 years old. And at the time, the hospital that I was using for my delivery wanted to do amniocentesis because they were aware that I had the S trait, and we weren't sure whether or not his father had the same trait. At that time, I decided that I would not do the amniocentesis because I wasn't comfortable with the risk, but also that the result of the amniocentesis would not make a difference to whether or not I would carry my child to term. So I decided not to do it. A couple of months later, I was invited to a focus group where they were talking about newborn screening. So that was 2006. Newborn screening at the time was being championed in Ontario by Lily Johnson. That's a name that we haven't heard here today, but she's the founder of the Sickle Cell Association of Ontario, and she is a champion for better outcomes for sickle cell disease patients. So I did the focus group, and in April of 2007, my son was born, and he was one of the first to be tested with sickle cell disease being added to this battery of tests that were being done at the hospital. About 4 months later, in August of 2007, I received a call from Dr. Isaac Odami. If anyone knows him, he is a hematologist at the Hospital for Sick Kids. And he had advised me at that time that the test had come back positive and that we should come down so we can do another test to make sure it's not a false positive. And so that he could also tell me what to expect going forward with my son with his illness. That visit was extremely helpful because it helped us to understand that although historically sickle cell disease has been, a bit of a death sentence for patients, it didn't have to be that way for us. He gave us, the hope of understanding that things were changing and people were living longer. And so now I have a 16-year-old who's taller than me. And I mean, if you see me, I'm not short. So if he's 6+ feet, then he's doing well and we must be doing something well. Part of that thing that we've been doing well is sending him to Camp Jamoke. That is a camp for children living with sickle cell disease. He's been going there since he was 8 years old. This summer will be his final summer attending camp. But what Camp Jamoke has done for my son and for many others who have come, it's allowed him to have a life like a child would have at camp, not worrying about, well, what will happen if I take a swim in Lake Ontario? Normally, kids were told at that time, don't spend time in the water, so many don'ts. But at Camp Jamoke, what they're able to do is explore these things. They do, rock wall climbing, they do kayaking, canoeing, you name it, they try it. But these are all things that they, at least for my son, he would not have tried if it was only for me. Because as he calls me, I'm a helicopter mom, and I tend to stay very close, and I tend to limit the things that he will try. When I'm not at camp, they make them try everything. And so what you get when you get your child back from Camp Jamoke is a child who has a renewed sense of confidence. He has, a network of friends who understand what he's going through. He has a refuge where he can go for a couple of weeks for the summer. There's medical supervision. Our doctors and nurses are recruited from Sick Kids Hospital. And so when they go away to camp, they see people who know them from clinic visits throughout the year, know what to expect from them if they should have a crisis, know how to give them their daily medication, all the different things that parents are afraid of when it comes time to letting their children go out and have certain experiences. So I just wanted to share that if you haven't heard of Camp Jamoke before, I encourage you to look us up. You can find us online at jamoke.org, or I believe I left a card at everybody's table. Throughout the pandemic, we actually changed our program to be virtual, and that was great. We were able to reach children from across Canada. But now that we're back in person, things are more challenging because funding, everyone should have encountered this post-COVID pricing everywhere you go. So the cost of camp has gone up dramatically. And so for the first time in 29 years, next year's our 30th anniversary, camp is threatened. The opportunity to send children to camp is threatened. So we do have 12 going on July 9th, but we've also had times where we've sent 40 children for a 2-week session. So to only be sending 12 shows you the difference in funding. We have no government funding. We've all talked about that. There's no government funding for sickle cell groups. And so all the work that we do is done by volunteers. And so Ms. Biba, people like Euless, Alvin, we all work together to try and make sure that the life cycle of a patient is being supported from beginning to end. Just like sickle cell disease affects the entire body, it affects the entire life. And together, I think we can continue to work to, make things better for everyone, both patients and the caregivers around them. Because as a parent, it's not easy to watch your child go through a crisis. It's not easy to say no to them to different activities because you're afraid that they're going to, have a crisis. So we need to just continue this work. So that's all I wanted to share. Thank you, everybody.
Okay, let's go to questions.
I mean, anyone can answer, but it's particular for Dr. Jude Maricena. I'm not sure if you have data in terms of blood donations and African people not being able to donate. Do we know if groups such as white South Africans are allowed to donate blood?
I don't know nothing about this, and this is a good question. I don't know, maybe someone from CBS can answer that question, so I don't know nothing about this, but it is a good question. I'm interested also to know.
Can I just add something?
Another question?
Go ahead. Go ahead.
Go ahead.
Go ahead, you can.
I was about to say that we were talking about in terms of donations and if certain people can donate things. I think that what we have to start thinking about is to remove this anti-racism stuff off the table and look at things pragmatically. This is why I am insisting that we raise $25 million to have our research done in-house. We will know what is necessary and what is not necessary. Because today we talked about malaria. How many of you know that there are drugs now being tested in Kenya, Uganda, and forgotten the other country that is being tested, and no one mentions it. The other point I want to raise is that we talk about the people who have AIDS and they can now donate blood. We hear advertisements saying that if you take this drug and you have AIDS, you can have your blood to the point where you can have sexual intercourse and it would not affect the person. We should be conducting similar research here. We should be writing policy papers to WHO to standardize the notion of what it is with respect to malaria. Nobody is going to do that work for us.
Thank you. So we can have one more question, I believe. Or...
That's it.
Thank you. What a day. Thank you, everyone. Thank you for being here. Thank you for sticking with us till the end. This was a very good day, I hope, for everyone. Sickle Cell Awareness Day doesn't end only on June 19, it's every day. Every single day, we have to keep raising our voices, amplifying our voices, so that you can see the reality of living with sickle cell in Canada. And it's the same. I sit on the board of the global organization. Everywhere in the world, it's the same. We have to change things. Because at the end of the day, with all going on in the world, we've seen it with COVID. There are no borders. It can affect you someday. It can be your loved one, somebody you love, or your friend's child. So let's work together. Let's get that registry. Let's come back here. The promise is maybe next year. I want to get Dr. Sena to promise that we'll come back here next year and show you the first data for the registry. And we're going to work for that and make sure that it happens. Thank you all. I see people here. Oh, by the way, my boss is here. Jenny Peters is here. This is from the team of corporate mental health at Health Canada. She's been here all day. And my former boss is here. And I got to tell you something about her. That's Liz Hamilton-Carrière from Public Health Agency. What she did when we started working together, it was during COVID. We've never met. And we were just working virtually. But she had to know me to know how to work with me. And she kept asking me questions. I'm like, this woman asks questions every day. So how many kids do you have? So what did they do? How are you doing? But she was talking about herself also, her kids, her grandkids. And I didn't know that she was really listening. And one day she said, well, Biba, you know, I think it was about Easter. She said, Biba, I'm a Christian. I donate blood twice a year, at Christmas and at Easter. But this year, I'm going to go register and I'm going to donate blood in honor of your son. And she's been doing it ever since. And she is a blood champion. She is an ally. And that's why we have to keep talking. Thank you for your gift of life. Thank you so much, Liz. So thank you. I will let Dr. Sena do the closing remarks, and thank you.
No, I will stay with me. It is just to tell you, what about having a full day conference next year?
Yes.
That will be my last words. And we have a film for a movie for like, it is like really short.
7.
So stay here and say if you have time.
You don't have to drive or a flight.
Yeah, yeah. That it is a very emotional movie. They are trying to have money for that, and I think it is also important. Thank you again, everyone. It was a pleasure, and let's continue the work. And j'ai envie de vous dire, see you at work.
Yes.
Allez, réponds-moi. Allez.
Comment tu te sens aujourd'hui? Hein? Je travaille pas ce soir. On va pouvoir écouter le match ensemble. Drogue pas.
Pourquoi je suis pas comme tout le monde?
Le docteur a dit que t'en aurais pas pour longtemps chez eux. Inquiète-toi pas avec ça, ça va bien aller.
C'est très bien que ça va pas bien aller. Regarde mon état.
Ben oui, ça va bien aller avec les médicaments que tu
Quels
prends.
médicaments? Tu sais même pas c'est quoi les médicaments que je prends. C'est toujours moi qui me les donne.
C'est quoi, tu veux pas refaire du sport?
Oui, je devrais faire du sport, mais...
Il faut garder espoir.
Garder espoir en quoi? Regarde, il est où mon frère?
On va trouver une autre solution.
Il n'y a pas de solution.
Je vais prendre une serviette, s'il te plaît.
J'ai plus faim, je vais me coucher.
Ah? Pourtant, t'as presque rien mangé.
Je veux juste aller dormir.
Mon chéri, t'as besoin d'énergie. C'est quoi? J'ai exactement ce qu'il te faut. sais, j'ai préparé ton dessert préféré.
Maman!
Avec... D'accord. D'accord. J'ai compris.
Excuse-moi, excuse-moi. Ça va? T'oublies pas de boire ton eau, ok? Si t'as besoin de quelque chose, t'hésites pas.
J'aurais pas le choix de rester avec Ali à la maison. On doit trouver une solution.
Je vais voir avec mon patron si je peux avoir plus d'heures au travail.
Je peux plus supporter ça, Abdoul. J'ai l'impression que ça me rend folle. J'essaie de rester forte, mais là, je pourrais pas le supporter si je perds un deuxième fils.
Oui, je sais. Mais je lui ai toujours dit de faire attention lorsqu'il fait du sport. Qu'il doit écouter son corps, mais non. Tu le connais, il fait toujours qu'à sa tête.
Est-ce que tu mets ça sur la faute Ali maintenant?
Je mets pas ça sur la faute d'Ali. Il de faire du sport, d'être avec ses amis.
Oui, mais c'est pas Ali. En ce moment, il ne peut pas y aller.
Pourquoi il peut pas y aller?
J'ai l'impression d'être la seule à me préoccuper de sa situation en ce moment.
Moi aussi, je m'inquiète pour lui. Qu'est-ce que tu crois? J'ai pas envie de voir mon fils souffrir. Je suis fatigué. Je suis fatigué, Farah. On se bat tous les jours pour avancer. Pour faire en sorte qu'il aille mieux. Et ces crises n'en finissent pas.
C'est pas de sa faute.
Je sais que c'est pas de sa faute. Ni de la tienne, ni de la mienne. Mais tu sais très bien qu'en tant que parent, on ne veut que le mieux pour nos enfants. Je veux que mon fils aille bien.
Arrête.
On n'a pas le choix, il faut aller à l'hôpital. Prends la chaise roulante. Prends la chaise roulante.
Ça va?
Je t'avais dit que ma première crise, je l'ai eue dans l'église avec mon père.
Non?
Il m'appelait le cascadeur. Parce qu'à chaque fois, il me voyait grimper dans l'arbre, il dit ça y est. Je lui dis, ben, cette fois-ci, si je fais une crise, c'est sûr qu'il va dire que c'est à cause de ça. C'est sûr.
Oui.
5 ans. Ça passe vite.
Oui.
soit déjà parti.
Je sens qu'il est. Hein? S'il regarde, tu seras prête.
Bonjour, papa. J'espère que tu te portes bien là-haut. Je voulais que tu saches aujourd'hui que je comprends. Tu as toujours été là pour nous, mais à ta façon. Je pense que tu serais très fier de ton fils aujourd'hui. C'est moi qui encourage les gens à aller faire leur traitement maintenant. Je suis tellement content que tu m'aies présenté M. Salon. L'association a tellement pris d'ampleur ces dernières années. Et il fait avancer les choses. Par contre, il y a de plus en plus de patients. Mais grâce à Emma Québec, les donneurs, les personnels soignants ont réussi à avoir nos traitements. Mais il reste beaucoup de choses à faire. D'ailleurs, j'ai été approché pour faire un projet de film sur l'anémie falciforme et pour sensibiliser les gens. Cher public, nous commençons une campagne de sociofinancement. C'est pour cela chaque geste que vous allez poser fera la différence.
Je supporte la cause pour l'anémie falciforme. Diane Lefebvre.
Claude Emmanuel.
Sébastien. Henry Grandmaison.
Nadège.
Sébastien Jean Dubé.
Michael Emmanuel Fana.
Litine. Nous sommes Ryan, Amiel.
Stanley. Jeffrey.
Béatrice.
Aminata Sambakuma.
Rissa Milungu. Marie-Sonia Ondo.
Mamoudou Kamara. Je suis atteint de l'anémie falciforme.
Wilson Sanon, le président fondateur de l'Association d'anémie falciforme du Québec. L'anémie falciforme est peut-être une maladie invisible, mais elle n'est pas invincible. Agissons ensemble.